Good evening, everyone. I am Dr.Murali from India. Today, I want to talk about vascular tumors of the nose, especially these fibroangiomas, hemangiopericytomas, and all these things. I am not covering juvenile angiofibromas, all those things, especially highly vascular tumors pertain to only nose. So the thing is, in such a tumors, the principles of the surgery are: one, pre-loading with the blood. That means pre-loading with at least 100 ml blood. That is point number one. Point number two, lightning fast surgery. That means you have to be debride the tumor or remove the tumor very fastly. That is point number two. Point number three is packing, immediate packing. Wait for some time, and then again preload with blood. Again fastly debride the tumor by debrider, or when the solid component is there, sometimes it is difficult to debride also. Then you have to use lux or tonsil holding forceps or any tissue holding forceps, bulk holding forceps, and then remove the tumor. You have to be very fast. When you're doing very fast, you have to be very careful. You should not breach the lamina papyracea and all those things. And immediately the whole nasal cavity is filled up with, the whole nose is filled up with blood. The minute you remove the tumor, immediately there is pooling of blood. Immediately you have to pack, big pack. So this is the principles of surgery are three. So in a resource high setting and resource less settings. In resource high settings, you have to use debrider and co-ablator. In a resource less settings, instead of debrider, you can use lux and tonsil holding forceps. Instead of co-ablator, you can use bipolar forceps. Whatever it may be, whichever the setting may be, the principle of the surgery is three. I am repeating again. One is preloading with the, I will show the video in next video how I have done that. Preloading with the blood 100 ml, 150 ml, and then fastly you have to remove the tumor. That is point. Preloading with the blood is the point number one. Point two is fastly you have to remove the tumor. Point three is immediately you have to pack it. That's it. Okay. Very recently, just a few days back, I have done this fibroangiomatous tumor on the left side in an unmarried girl, 20 years girl. And that patient asked me, she doesn't want any scar on the neck or face or any other area, nose. So that means I cannot take external carotid control or midfacial deglobing. So I have done like this, immediately debulking. I have done like fastly, I have debulked the tumor, and then sphenopalatine artery I ligated it. But after that, so immediately I have done very fastly the tumor surgery. But after that, what I thought is, instead of that, I would have done in this girl, keep the patient in tonsil position by keeping Davis Boyle mouth gag, and keep a 70-degree scope to the oral cavity and see the nasopharynx, and then ligate the sphenopalatine artery with simple bipolar forceps. I mean, like we do in adenoidectomy. So that way we can reduce the vascularity of the tumor. And then after that, once I ligated the sphenopalatine artery, cauterized the sphenopalatine artery, there won't be much bleeding. I got that idea after the surgery. Okay, that is another option. So there are four options. One is very fastly removing the tumor with the debrider or tonsil holding forceps or lux forceps or any tissue holding forceps, and then cauterizing the sphenopalatine artery. That is by direct route. Second one is sphenopalatine artery, first sphenopalatine artery ligation through the nasopharynx. I think that will be better. And the third one is midfacial deglobing through cardiolac, keep an endoscope, and through the maxillary sinus you drill the sphenopalatine artery area and cauterize it. That is the third one. And the fourth one is external carotid control. So in this case I would have done tonsil position and keep a Davis Boyle mouth gag and 70-degree scope, and I would have ligated it to the nasopharynx and then remove the tumor. I think that will be better. So that is the message I want to give. 4 methods. Whatever it may be, the principles are preloading with the blood. That is especially useful in children and lean patients, especially the young females and malnourished patients. You have to preload with the preload the patient with 100 or 150 ml, and then only you remove the tumor, and then you pack it. And this cycle has to repeat until you completely remove the tumor. So in children and even in JNS also in children, it is always better to preload the child with blood. So that is the message I want to give. Thank you.